Thank you very much for inviting me. It's good to know what's coming up because you will see a lot of changes in your clinical practice. So before I go into talking about high sensitivity troponin T, I just want to give you a little bit of history of cardiac markers in London Health Science Center and St. Joe's Hospital. Back in 70s and 80s when I joined London Health Science Center or University Hospital in 1989. At that time, we were doing what we used to call enzymes, as a creatine kinase and its isoenzymes, and lactate dehydrogenase and its isoenzymes. So as the patients comes to emerge, we'll draw the blood sample, come to the lab, and we were able to do CK and LD. And LD was used as a late marker, and the CK was used as an early marker. At that time, we were able to do the isoenzymes, which were done by electrophoresis. You take agarose gel and do the separation of the bands and find out CKBB, CKMB, and CKMM. But that was done next day. And sometime if it's a weekend, if it's done on Friday, the emerged physicians won't get the results until Monday. So that was our turnaround time for doing the CK. So when I joined after 2 or 3 years after that, at that time there was a lot of changes happening, especially in the immunology area and the monoclonal antibodies. And the assay, commercially available assay, became available for CKMB, where they were able to use 2 monoclonal antibodies and create a specific assay for CKMB. And that we could run it on the immunoassay analyzers and provide the results within 3 to 4 hours. So CKMB, which was considered as the gold standard, was available to the physicians within 3 to 4 hours of turnaround time, which was a big change. So we continued doing that CKMB at the UH, at the Victoria Hospital and St. Joe's for almost like 10 years until the troponin T came early 1990s. And that's the time when we associated with one of the commercial company, got the antibodies, and we started doing troponin T assays within our hospital by handmade assay, which was we couldn't use clinically. But in 1995, the troponin T assay from Roche became commercially available, and we were at the University Hospital. We were the first hospital to use the troponin T assay here at University Hospital. So we used troponin T for 3 to 4 years. The main problem came out again was in the renal failure patient. At that time, it was not known that the troponin T is falsely elevated. It was considered as falsely elevated in renal patients. So then we switched to troponin I, which was a little bit more specific than T, and that's the instrumentation we had, so we didn't have to have separate instrument. And troponin I, we kept on using from 1998 to 2008. And in this period, we stopped doing CKMB completely from the hospital. So troponin, and then in 2009, we switched our instrumentation in clinical biochemistry from Beckman to Roche, and we changed to troponin T again. And that's the 4th generation troponin T, which we are using currently. And I'll show you what are the problems with the 4th generation troponin T. And now in 1st of February, we will be switching to troponin T, which is the high sensitivity one. So before I go into that, it's very important to understand the basics, that when we talk about sensitivity and specificity, what these are, what they will mean, because we are going into high sensitivity, and it's going to affect that how we do the interpretation and how many false positive and false negative we get. So we go back to our basic of 2x2 decision matrix. We have gold standard. Unfortunately for cardiac markers, troponin is a gold standard, and we evaluate something that is also gold standard. So it becomes very difficult. So if the disease is present, test is positive, is true positive, and if the disease is absent and the test is negative, is true negative. And then we have false negative and false positive. What we wanted to do is cut down the number of false as much as possible. So if you look at the sensitivity, which is true positive divided by true positive plus false negative is in the denominator. So if we have false negative almost 0, we will have 100% sensitivity. Similarly, in the patients who have disease absent, the specificity is true negative divided by true negative plus false positive. So if we have false positive 0, our specificity will be 100%. So again, if you look at the negative predictive value, which is true negative divided by true negative plus false positive, we make it false negative 0, our negative predictive value goes 100%. And that's what we're going to be seeing, that how by switching the decision threshold, instead of going towards the right, we go towards the left, we increase the sensitivity, and we get the high negative predictive value, which is shown over here when we look at the test interpretation. So this is the non-disease population. We know that these patients don't have MI, and let's say this is our decision threshold. So the one towards the left, they are true negative, one towards the right is false positive, because we know that it's a non-disease population. But imagine that if we move our decision threshold towards the right, we increase the specificity because our false positive, which is in the denominator, goes almost close to 0. If your decision threshold is over here, it will go to 0. Our specificity will be 100%. The sensitivity, we look at the disease population. This is our decision threshold. Here we have true positive, and then we have false negative. And if we move our decision threshold towards the left, we decrease it, which we'll be doing in the high sensitivity troponin assay. Our sensitivity will go up, and our false negative, because our false negative are going almost close to 0. So it will be ideal situation if we have non-disease population and disease population separated from each other, so that we can have a comfortable decision threshold. But that's not the situation in real life. We have quite a bit of overlap between non-disease and disease population in most of the tests. So we have to find out what is the best one depending on what we want it to use for. So if we apply the spin and snout formula, snout is the one which is working out for high sensitivity, because this is our decision threshold. We are moving towards the left. What we are doing is we are increasing the sensitivity and increasing the negative predictive value. So if we have our decision threshold over here, almost we can have 100% negative predictive value and very, very high sensitivity. So keeping that into mind, what we wanted to achieve today, just some of the things which we want to know. What are the limitations of current troponin T? Why are we switching it? That's the question all the time comes up. And I can give easy answer for that, but I think we had to go beyond it. The easy answer is that the company is changing it, so we had to change it. So, but that doesn't work. So what is high sensitivity troponin? What will be the unit of measurements? What is the 99th percentile value? How does it correlate with the current troponin T? So we have done some of the correlation between the old and the new one. And the algorithm for the diagnosis of AMI, we have a draft version of algorithms. We will take your input, and from there we will sit down and with Emerge and cardiology and come up with the algorithms which is comfortable for everyone over here. Then the implementation date for LHSC and St. Joe's Hospital. So before we go into that, we had to look at the universal definition of myocardial infarctions, which came in 2007, and it was published in European Heart Journal in 2007. And any papers you look at it, I think they go back to this universal definition. I'm not sure how commonly or how widely these are used, but in publications they are used quite a bit. So according to these definitions, cardiac troponin T and I are the preferred marker for the diagnosis of MI, and which we have recognized it. And that's why we took out CKMBs and CKs and LDs and everything, and focusing on troponins. The second point is very important. In the clinical setting, consistent with myocardial ischemia. So they're saying that it has to be the clinical setting which is consistent with myocardial ischemia, detection of rise and fall. Number one, consistent with myocardial ischemia. Second is that detection of rise and fall with at least one value above the 99th percentile. So third one is that at least one value should be over 99th percentile for the diagnosis of MI. And And the last point they are making point is that because the assays at that time were not very sensitive, and they found that the error rate was significantly very high. So they suggested that optimal precision at the 99th percentile for each assay is defined as a coefficient of variation should be less than 10%, because some of the assays at 15%, 20%. So fourth generation troponin, for which we have our cutoff of 0.03, technically we're supposed to have CV or coefficient of variation of less than 10%. We can get 10%, that's only in the very ideal situation when there is the best kit which we get it and the perfect technologist who's working up and the perfect situation. But in general, we get between 14 to 15% CV. It's very hard to get less than 10%. So what is the problem with the current situation? The major limitation is the poor precision at the 99th percentile. As I mentioned that at 0.03, it's very difficult to get 10% CV. The second one is that the current assay cannot measure troponin in healthy reference population. It's a poor analytical sensitivity. That 0.03, when we report less than 0.03, that population has both healthy population and also patients with the MI. So it's all hidden underneath. You cannot determine the levels of troponin in healthy population because everyone will come less than 0.03. So we don't know what the actual number is. So because of poor sensitivity, there is a high risk of missing AMI, and the diagnosis of AMI requires prolonged monitoring. In this one, we know that sometimes the first troponin, or most of the time, the first troponin is not good enough, and you have to do the second one, and then you have to do the third one to really rule out. So we have delayed rule in and delayed rule out. So we have this period when the troponin, the existing troponin, doesn't rise. We call it as a troponin blind interval. So troponin blind interval in the fourth generation is much longer as compared to what we'll see in the fifth generation, or the high sensitivity troponin. So what is high sensitivity troponin? It's exactly the same as the fourth generation, other than it's more sensitive at the low end. So the level 0.03, which we were able to detect with the fourth one, now we can go almost like 10 times lower. We can go to 0.003, which is 10 times more sensitive than the current one. The assay uses the same antibodies. So the epitope on the antigen is exactly the same which we were using on the fourth generation, and which, when we look at the comparisons, you will realize that it's not too different. Only thing what they have different is they have optimized the assay by changing the time and changing the buffer concentration, and adding something in there which can increase the sensitivity for the same antibody pair. So it can measure, so because of that, it can measure 10 times lower levels. It's more likely to detect a rise early compared to the regular troponin, of course, because of the highest sensitivity. And the snout, the sensitivity is how high, so we will, it will be better to rule out the test. So one way is that we go with the same units we have for the existing assay, go with the micrograms. But I think the general consensus is that using 0.003 or 0.005, it can be very confusing. So the worldwide, they are switching to nanograms per liter instead of micrograms per liter. So that everyone has to get used to, because the numbers will be higher. Instead of 0.03, we will be seeing 30, or instead of 0.1, we will be seeing 100. So it will be absolute higher numbers. So 0.01 is 10 nanograms, 0.03 is 30 nanograms. So sometimes it can scare that, troponin is 100. It could be very high, but it's in the old unit is 0.1. So what is the 99th percentile value? So the studies have shown the 99th percentile for the high sensitivity troponin is 14 nanograms per liter. So here is the healthy population, 533 healthy subjects taken, and about 70% of the subjects, these healthy subjects, have measurable levels of high sensitivity troponins. Now compare this with the old troponin, all of them would have been less than 0.03. But now we will have a number. We'll have 5 or 7 or 8 or 10. They will be, healthy population will be in the measurable range. About 30% still will be less than the detection limit, which in our case will be 0.003, which is 3 nanograms per liter. So before we bring any assay, we do the comparison with the existing one. And here is the regression analysis with the existing troponin. On the x-axis, we have 4th generation troponin T, and on the y-axis, we have high sensitivity troponin. Look at the correlation, straight line, very good. It's starting from all the way from 3 to all the way going up to more than 5,000 nanograms per liter. So as I was saying, the numbers will be higher. You'll be seeing 5,000, 6,000 also in some situations. So here is the equations. Y is equal to 0.8625. The slope is 0.8625, and the intercept is 4.5, and the correlation coefficient is 0.994. You can't get better than that. It's exactly the same because, as I said, the antibody pair is same. But we are not too much interested in when the troponin is so high. Let's see what happens if the levels are lower. That's where we are achieving the sensitivity. X-axis, again, 4th generation. Y-axis, we have high sensitivity troponin. This is the equation. One slope is 1.08, plus the intercept is about 18.63, and the correlation is 0.9767. So here is the value from 20 to 100. Here you can appreciate that our current cutoff, which is 0.03, 30 nanograms, will give about 50 in the high sensitivity troponin. So the rule is that if the values are under 100, you just convert into nanograms and add about 20. So if it was 30, it's 50 in the new high sensitivity troponin. But as the levels go above 150, they are almost 1-to-1 relationship. So this difference we'll see only at the lower end between the old and the new one. So here I'll just to give you examples of some of the patients which we did, which came to the eMERGE, and we followed it so that we can see the comparisons between the old and the new troponins. Here is this patient, 83 years old, with the chest discomfort, right coronary artery, instant restenosis, 90% blockage, and this patient was restented. The patient came in the hospital to the eMERGE. These are the initial of the eMERGE doc. I guess you can recognize, I can't. So it's came at 10:28. The troponin, our existing troponin was less than 0.01, which is undetectable. High sensitivity troponin, 8. So we can measure the levels because our levels are starting from 3 and over. So the numbers 8 will be, you will receive it. The second troponin, which is at 259, which is about how many hours? That's about 3-4 hours. Our existing troponin is still 0.01, and the high sensitivity troponin jumped to 27. So that's a significant jump. The third one, when it went to the cardiology, you can tell from the initials, 0.06, our existing troponin became positive, 0.06. Our high sensitivity has gone to 72. And here you can see the relationship also is becoming very close, 0.29, which should be 290 in the high sensitivity is about 242. 0.14 should be 140, is 151. So this is the correlations you see in a patient coming to eMERGE. Here is another one. You can tell from the initials who the eMERGE physician is. Troponin T. This is 57-year-old male with a chest pain, shortness of breath, smoker. There was no EKG results I saw in the chart at least, and suspecting COPD. The first troponin, 0.01, it was done at 9:56. High sensitivity troponin less than 3.0. Second one, done after about 2.5 hours or 3 hours. 0.01 in the existing one, 4, still negative. The third one done at 17:56, less than 0.01. Our new troponin is also less than 3. So it's showing that it's correlating very well for the patients with the non-MI. This is another one, 83 years old, male admitted to eMERGE with unstable angina. He had PCI on November 21st, which is somewhere over here, November 21st, with dyspnea, diabetes, and depression. Troponin our existing one, less than 0.01. High sensitivity is 16, it's a little bit above the 99 percentile. The second one, 0.01, 14. Third one, 0.01, 12. Fourth one, 0.01, 16. And here it's hovering around close to 99 percentile. So I guess this is more in the unstable angina type of group, but it's a little bit higher than 99 percentile, so you can categorize more into the high risk. This is the another one which you find with the chronic kidney disease, which is another can of worms. So you can see the patient came to the emerge and with a troponin T of 0.07, high sensitivity is 85, second one 0.06, 77. So troponin is declining. So it appears that the patient had some kind of episode and it's going down. So it's just to show you the comparisons between the old and the new troponin. So when we look at the patients and we are looking at acute coronary syndromes, the literature shows there are two main lines. Either we have persistent ST segment elevation. So this group is easy. We really don't need to do troponin in this group because these are already, we know that they are specific and they have STEMI. But the recommendation is to use one troponin just to confirm the diagnosis, and these are high-risk group patients. And the second group, completely clear non-MIs, and we do two normal troponins and look for, see if the both of them are negative, and then if it's a unstable angina, then it's a low risk. But if you do the two troponin and if the troponin is positive and it goes over 99 percentile, and then they go into this NSTEMI group, which is called non-ST segment elevated MIs. So on the basis of this, we are suggesting one of the algorithms which we'll be discussing later on once Karl goes through all the clinical stuff. Here, patient coming to the emerge, we do the baseline troponin. We look at the first troponin, see if it's less than the lower limit of detection. We put 5 over here, but we can change to 3 because lower limit of detection of the blank is 3. But if we say accurate measurable levels are 5. So depending on what we need, we can put 3 or 5. So if the level is less than 5, there is quite a good clinical evidence showing that the negative predictive value is very, very high. In most of the situations, you might not need to do the second troponins. But if the clinical suspicion is very high, then we can always do the second one 3 to 6 hours later in any of the situation. The second group is between the lower limit of detection and the 99 percentile, which is 14. So here, we don't know if the patient came out early. The high negative predictive value is very high, but it's suggested that if we have suspicion, we can do the second one. And the third group is between 99 percentile and 100, where it's highly recommended that we do the second one 3 to 6 hours and then look for the change. So the change which we have come up with is 10. If the change is less than 10, it's most likely acute myocardial infarction is unlikely in this situation. And but if the suspicion is high, again, still we can do 3 to 6 hours. But if it's greater than 10, the difference, then acute myocardial infarction is highly likely. So this delta value, the 10 which we are putting 3 to 6 hours, is more to increase the specificity. Because when we put 99 percentile as 14, you will see a lot of patients running in the range of 25, 30, 40, and that the one which you used to call troponitis will become a bad troponitis because you'll see lots and lots of elevated troponin in non-ACS patients. But if the troponin is higher than 100, then the predictive value is very, very high.
Vipin, your numbers, is it correct to say only 30% of people will be less than 5 initially then? Because you said only 30%.
The literature suggests about 25 to 27%, less than 3. You can sort out only with one troponin.
So 70% of people, that won't be helpful to us. Like 30,
yeah.
Only 30%
yeah,
of people.
Exactly.
Will,
Yeah.
We'll have to do repeats in 70%.
Yeah, that's suggested. 70% you have to do the repeat. Okay, so what are the possible implications because of the high sensitivity? for more cardiology referrals, if we don't follow strictly that the patients on which we are doing the troponins, we don't do indiscriminately, we do patients who have symptoms of ACS. That's the most important message. More NSTEMI, subendocardial MI, which we used to call, at the expense of unstable angina. So we'll see more shifts going from unstable angina to NSTEMI. Possible more acute cardiac investigations, because if they are in cardiology, they're going to do the investigation. More troponin tests, and therefore more spent on the diagnostics, and that's a challenge for us. So that's why we had to go and tell that we use troponin properly. The advantage will be, hopefully there will be early discharge, especially in those patients where we have less than 3 or less than 5. And also if we do the second one, we might not have to wait for 6 hours. We can do after 3 hours and see that if we can rule out. So hopefully it will be better quality care. Here we see for the lab, one of the lab in Europe teaching hospital, they used to do with the 4th generation troponin, about 800 troponins in a month. When they start using high sensitivity, they jump about 20%. They're using higher. But our aim is to keep at that level. So what is the key message? The key message is order high sensitivity troponin only in patient with high suspicion of ACS. That's one way to cut down your troponins. Use serial measurements to differentiate an acute from a chronic elevation of high sensitivity troponin. Remember, high sensitivity troponin is a marker of myocardial injury and not necessarily a specific marker of myocardial infarction. So that thinking of gold standard CKMB and troponin T is specific, I think we had to get out of that. We know that troponin can be elevated in a lot of patients with non-ACS patients. High sensitivity troponin results should always be interpreted in the context of clinical assessment and never in isolation. I think clinical assessment still takes over. And we have seen some patients, Dr. Kumar Sridhar, he asked me to do one of the patient on which there was a more than 90% block in LAD when he did the PCI. And the 4th generation troponin was always less than 0.01. And we did the 5th generation high sensitivity. Still, the troponin was within 99th percentile in that patient, while the blockage was more than 90%. So the diagnosis was based on clinical assessment, which means the patient has unstable angina, but did not have MI, so it was picked up early. So clinical diagnosis is useful. Implementation date will be starting on February 1st, 2012. There will be an overlap period of 2 weeks during which we will do our existing current troponin 4th generation and the high sensitivity. So it gives you 2 weeks of period so where you can get comfortable with the high sensitivity one. 4th generation will be discontinued on 8 o'clock on February 15th, 2012. And if you have any questions, concerns, do not hesitate to contact me.
I think I just missed it. Is this the same time to rise from event as with the regular troponins? Like, we have troponin blind time still with this one?
It's the rise. Rise is the same because it's sensitive. In the old assay, we could not detect it because our cutoff was 0.03. So the rise probably was there between under 0.03, which we couldn't notice it. But now with the high sensitivity, because we get the numbers, so we can see the rise. So we'll pick up early.
I'm just wondering, so we get someone who has the less than 5, or we just have them early, we just do repeats with clinical.
Exactly. For those ones, we need to repeat it. Yeah.
Thanks.
Yeah. So we are hoping that 3 to 6 hour second one you do. So majority of the times, 2 troponin should be good enough. But sometimes, if the clinical indication is there, you need the third one, so you need it.